Okay, so Jeannie, should I start?
Yes.
Okay, great. Welcome everyone, and thank you for being here. It's my pleasure to introduce Dr. Peter MacIntosh, who will be our speaker today. Dr. MacIntosh is he does so many things for our department. So I'm the chair of ophthalmology here at UIC. Peter is the director of our Global Ophthalmology Fellowship. He's the director of our residency program. He's also director of the Neuro-Ophthalmology Service. And what he's going to talk about is this intersection between what he does clinically and the international work that he spearheads for us in the department. To give you some background about Peter, Peter did his residency at Cook County. He did his fellowship here at UIC and then stayed on faculty. And we actually started here at the same time around 7 years ago. So, for me, it's been a tremendous joy to work with Dr. MacIntosh, who leads so many things. He does a lot of work now in India with our partners at the Aravind Eye Center. He also does a lot of work in Honduras and also is developing partnerships in Kenya with our global partners and also in Rwanda. So, I think that Peter is a great example of a global citizen and the power of the work that can be done here at UIC. So with that, I will introduce Peter. Again, thanks for being with us.
Thank you, Dr. Chan, for that very warm welcome and introduction. Let me just share my screen. So yeah, it's true. I wear a lot of hats. But I do like to find a way to connect these. And I do think that one way that these sort of all meld together has to do with program and curriculum building and development. I'm not going to talk too much about that in today's talk, but that's really the way that I see myself moving forward with all of these seemingly divergent roles. But where they come together is that we're building curricula, whether that's here or overseas, building programs to develop people and build capacity throughout the world. So that's really how I see my role developing in global ophthalmology. But today I wanted to talk a little bit about Ethambutol Optic Neuropathy in India, because this is a project that I worked on with one of my colleagues in India at the Aravind Eye Center. And so I thought this would be an interesting springboard for talking about collaboration and sort of how this has impacted their population. I have no financial disclosures. So here is a chart talking about the trend of vision loss, so blindness or moderate to severe vision loss from 1990 to 2050. As you can see, this chart shows quite a large increase in the number of people that we think that we might have to treat across the world. Some of this has to do with the aging population, as well as other conditions that can cause vision loss. But the point is, there's a large global burden of blindness, and we have to find a way to try to address this. Now, before I talk about ethambutol, I wanted to introduce you a little bit to the Aravind Eye Center, who I did this work with, because it's a phenomenal institution. That way you can have a better understanding of who I was doing this work with. And they have really found a way to try to address this. So about, I guess, 7 or 8 years ago, there was a global action plan that was proposed through the World Health Organization. And it was had an eye component to it to improve eye health for everyone over the next 5 years, which seems like a pretty short period of time, and to reduce the burden of blindness by 25%, which also is a huge number. But the good thing about these are definable periods of time, and it's a definable number. If we can identify how many people are blind now and how many people are blind in 5 years, these are things that could be calculated. And I'm not going to harp too much on the results of this, but more importantly, I wanted to talk about the pillars that were put in place to try to achieve these, because I think this is how we can try to address these issues if we can understand these pillars. And then I'll show you how Aravind has actually tried to put these into place and how successful they have been. The first point is to have a comprehensive eye care services for all the causes of blindness, including prevention as well as treatment and rehabilitation. The second one is access for everyone, including the poor and indigenous persons and women and those in rural areas. The third is to have the eye health integrated into the national health system. It has to be supported at the highest levels. And finally, there has to be a point of care payment system that doesn't prevent access because a patient can't afford care. So this is the sort of philosophy of Aravind. You can see many of these are in here: financial sustainability, quality, efficient service, reaching the people, high volume, giving value. And this is all surrounding their main principle, which is patient-centered care. So to address the first pillar, to build capacity with a local training program for all levels of ophthalmic personnel. So we can't just talk about training doctors. To deliver comprehensive care, we also need technicians, opticians, clinical assistants, outreach coordinators, healthcare managers, and also all of the subspecialties within ophthalmology. There's a huge burden of cataract, of course. That's what many, many people talk about when we talk about eye care globally. But there are many other conditions: diabetic retinopathy, glaucoma, ethambutol optic neuropathy, which we talk about today, that can benefit from subspecialty training. And so being sure that a comprehensive team is being developed is critical. So this is the first step. And Aravind has this. They train all of their physicians and all of these people within their system so that they can provide comprehensive eye care. And then reaching everyone becomes the next issue, particularly in low and middle income countries where transportation can be of a challenge. Providing a way to screen people who can't make it to a tertiary care center. And that can be done by having many institutions spread around. So this is in the state of Tamil Nadu in the south of India, where they have many large tertiary care centers, smaller ones. But more importantly, they have a number of outreach clinics. So from the tertiary care center, they go out into the community, into the rural areas to screen patients, and then have a system of bringing them back to the tertiary care center for treatment if and when that is required. And so this is how they're able to reach all of their populations. And these are examples of the screening clinics, where they're doing pediatric screening, glaucoma screening, and then depending on the findings there, these patients can be transported as needed back to the main campus. Critically important is to have support and leadership, support from the highest levels of leadership within the government, so that these can be disseminated to all of the regions throughout the country. So as far as vision is concerned, in India, there's a national program for the control of blindness and visual impairment. And this is how they integrate eye care into their system at a national level. And then finally, how do patients afford the care? And, Aravind has an incredible model, and they've been around for about 50 years with this model, and have proven how successful this can be. In fact, so much so that the Aravind model is studied at a number of business schools throughout our country and around the world, to how you can make a system such as this one. So part of it depends on patients who can afford care. As you can see here in that blue circle, patients who are independently wealthy or have insurance may then provide fee-for-service or purchase premium services that support the main hospital. From those funds, they then pay that cover the services that they have, but then there are funds that are taken from that can then be used to support a free eye hospital for those who can't afford to pay, and the eye camps that we talked about, these outreach clinics. Interestingly enough, patients are often asked what they think they can afford, and this really seems to work to support basic services for those who can't afford it. And so this is the system that they have been working with for, as I mentioned, for 50 years, that has been extremely successful at delivering care to their population. The final part is the Aura Lab. Some of you who are familiar with ophthalmology know how many instruments and how much technology we use. And a lot of this stuff is expensive and can actually be cost prohibitive. And what Aravind has done is created an Aura Lab, which is a lab that can actually make many of the things. So for example, for cataract surgery, the intraocular lens, the sutures, surgical blades, the eye medicines that we use topically or as injection into the eye. All of these can then be produced at much more affordable costs to allow them to maintain their level of care and yet have all the supplies that they need. So how has this helped them achieve this? And this is a graph that I like to talk about that shows the cataract surgical rate, which is the number of cataracts per million people on a graph related to the gross domestic product of a country. And not surprisingly, you can see the USA is way up here, as are a number of other well-developed countries. We have a lot of cataract surgery relative to our high GDP. But interestingly enough, India, whose GDP is similar to countries like Sri Lanka and Nepal, has a relatively high cataract surgical rate for its GDP. And this graph wasn't meant to define why that's the case, but certainly I think having meeting the four pillars we talked about, having institutions like Aravind, and there are others in India. Aravind is not the only example of eye care there, but all of these are examples of things that when put together can have a tremendous impact on, in this case, the cataract surgical rate. And if we use that as a surrogate for eye care in general, we might extrapolate that they're delivering relatively good eye care, maybe better than expected for their gross domestic product at least. Anyway, so those are the people that I work with in India, and it's truly a pleasure to work with them. And we've worked on a number of projects, and I thought this one might be interesting to talk about. It's ethambutol and how it can affect vision. And here we were actually looking at visual function, visual evoked potentials to try to identify, is there a way that we can predict how a patient might recover from ethambutol optic neuropathy? So this is the structure of ethambutol. And this is not going to be a biochem or organic chemistry lesson, but I show that because the important thing about ethambutol is that it can chelate certain elements, importantly zinc and copper. And these are elements that are important for optic nerve function and optic nerve health. In fact, for patients who have unexplained optic neuropathies, sometimes copper and zinc are levels that I will check in the blood to identify if there's a deficiency there. So ethambutol can chelate these and pull them out of circulation for use in the optic nerve, and therefore, in theory, lead to optic nerve dysfunction. The incidence of ocular toxicity from ethambutol across the world is about 22.5 per 1,000 persons treated with ethambutol. We do think and know that it's reversible to some degree. The vision loss is bilateral and painless, and it can start really at any point after starting ethambutol, but typically within about 4 to 12 months is where we see this. There are a number of important risk factors that we know of. Importantly, age. The older a patient is, the higher is the risk of ethambutol causing damage. The duration of use, the dose of the medication, these are not surprising. But additional ones are hypertension, renal disease, diabetes, and alcohol and cigarette use. And these last two we know are independent risk factors for optic nerve damage. There are a number of, there's another important condition where we talk about alcohol and cigarette use, and that's Leber's hereditary optic neuropathy, which is maybe one of the best studied genetic diseases. This is an maternally inherited mitochondrial condition, Leber's hereditary optic neuropathy, where the mitochondria become dysfunctional, especially in these high use macular papular bundle cells that subserve our central vision, and alcohol and cigarette can exacerbate that. So this is a well-described phenomenon, alcohol and cigarette use, in terms of exacerbating or leading to optic nerve dysfunction. A quick note about optic neuritis versus neuropathy, because I often see these terms used interchangeably, and they're related, but they are a little bit different. Optic neuritis is this what we see on the left. And as we all know from medical school, itis implies inflammation. And so this is inflammation of the optic nerve. The inflammation causes pain. And when you turn the eye left, right, up, down, it torques the optic nerve, and that causes pain that patients feel. Often optic neuritis happens in one eye. It's monocular, so the vision loss happens just in one eye. So they have monocular pain with eye movements, monocular vision loss. And importantly, on the MRI, there's enhancement. There's gadolinium enhancement on the MRI, which you can see here with those red and yellow arrows at the site of that inflammation. Optic neuritis is most classically associated with multiple sclerosis, and it can be one of the presenting symptoms, actually, of multiple sclerosis. And we treat this with steroids and other immunomodulatory medications. Now, when the optic neuritis resolves and goes away, that then leaves you with optic neuropathy. And there are many, many causes of optic neuropathy. Optic neuropathy is sort of a catch-all word. It just means the nerve is not working, but it can be caused by many, many things. And so optic neuropathy can be the result of optic neuritis, but optic neuropathy can be from any cause of optic nerve atrophy. Many other causes of optic neuropathy are painless. Here I mentioned the remote optic neuritis, someone who had this in the past and it's resolved. Ischemic, so non-arteritic anterior ischemic optic neuropathy or giant cell arteritis can cause an ischemic optic neuropathy. That one tends to be associated with headache, but not pain with eye movements. Importantly, compressive lesions that push and crush the nerve and damage the ganglion cell axons can also lead to optic neuropathy. And then finally, the one we're talking about today is toxic or nutritional, which tends to lead to symmetric and bilateral and painless vision loss, which we'll talk about. So for these patients where we suspect ethambutol optic neuropathy, history is the most important at clinching this diagnosis. These patients have a subacute vision loss, which might happen over, maybe a few days, but maybe weeks or months. As opposed to optic neuritis from multiple sclerosis, which is, over hours to a couple of days. Giant cell arteritis is sudden and immediate, but this one is maybe a little bit slower. We talked about bilateral and symmetric, like this is toxic, affecting both nerves pretty symmetrically. These patients don't have pain because there's no inflammation. This is not an inflammatory problem. And then, of course, you're going to get this history of ethambutol use. Many of these patients will have imaging and there should not be any enhancement of the optic nerve. Again, this is not an inflammatory problem. We know that this is dose dependent. And here are some of the doses that have historically been used: 15, 20, 25, 35 milligrams per kilogram per day. And then on the right side, you can see the prevalence of optic neuropathy from this. And at lower doses, the risk is actually quite low, 1 to 3%. But then it becomes quite exponential as we go up to 25 and 35. And in fact, 35 is a dose that is not recommended because of data like these. Symptoms and signs, these can lead to mild to severe vision loss. And again, for those of you who aren't ophthalmologists, let me just give you a little bit of background, right? I think you all know 20/20 is what we define as normal vision. This is measuring vision at 20 feet. And so what 20/20 means is that your patient that you're testing can see at 20 feet what a normal person can see at 20 feet. That's the definition of 20/20. There's also a sort of physics definition, which I'm not going to get into. Another point I should make is, we're in the US and we're one of the very few countries that measures vision in feet. Most of the rest of the world measures this in meters, and it would be 6. So 6 is the equivalent to 20/20. Mild vision loss is typically in this 20/30 to 20/50 range, which you can see in the red box. Severe vision loss, that's mild. Moderate vision loss might be this 20/70 to 20/100 range. And then severe vision loss is defined as this 20/200 or more. And in the US, at least, that's the definition of legal blindness. So the severe vision loss is, you can only see the big E, or you can't even see the big E. You can only maybe see hand movements is the next step. And the step after that is light perception, where you can't even see movement, but only light. And after that, we then proceed to no light perception, which is the absolute loss of all forms of visual perception. So we'll talk a little bit about that. Other signs, symptoms are the decreased color vision. This is an important one for optic neuropathies. Optic nerve diseases tend to affect the maculopapular bundle. I've mentioned that before, and what that means, those are the ganglion cells that go from the macula, which is the area of our central vision, fine discrimination. When you're reading, you're using your central macula. So those fibers are a little bit more susceptible to damage from neurologic processes such as this one. And those are also important for color perception. And so patients with optic neuropathies tend to lose color vision, which is an important distinguisher from glaucoma, which is another type of optic neuropathy that is related to high eye pressures. That one, interestingly, they don't lose color vision. And so that's an important differentiator for us as ophthalmologists. And then next is the visual field, is another important test, which I guess I'm going to get to in a moment. Here, I'm just showing you a picture of the optic nerve. And these are relatively healthy looking normal optic nerves. The color, this orangish pinkish color, as well as the blood vessels that emanate from it and move to the superior and inferior parts of the retina. This is what a normal optic nerve would look like. Yeah, I think that might have been the wrong place. I apologize about that. So here, I'm actually now talking back about the visual field. And just a quick lesson, again, for those of you who aren't ophthalmologists about visual fields, I think all of you who have gone to medical school will recognize that this is a bitemporal hemianopia, and that this is something that we see when there's compression of the chiasm, for example, from a pituitary tumor. But this is not how most visual fields look that we are doing in the clinic. And here, this is a large cellular mass, which is, you can, with those solid arrows pointing at this large mass, and then the open arrow at the top is pointing to the chiasm, which is kind of very splayed out and flattened. And so this patient, not surprisingly, might have a bitemporal hemianopia or even worse. This is a huge tumor, huge. But this is really how I might look at visual fields. So this is called a Humphrey visual field, which is an automated machine. The patient puts their head in this bowl, and then there's flashing lights inside, and the patient clicks a button when they see a light, and then this machine calculates the areas where they do and do not see. So this is one of my patients with a pituitary tumor and a bitemporal hemianopia, which you can see again very clearly. This is really easy to see. This is also a bitemporal hemianopia, but this is a different type of visual field machine, and this one is called a Goldmann. And instead of the machine marking in black the areas that the patient can't see, this machine focuses on circling in colors the areas where the patient can see. So this patient has a bitemporal hemianopia, and you can actually see these hash marks where they've marked the scotoma where they can't see temporally in the right eye. And I should have mentioned that earlier. The right eye is on the right side, the left eye is on the left side, and we view visual fields the way the patient is seeing it. And so those blue, red, and green circles are where the patient has vision on the nasal side. And so here is a patient with Ethambutol Optic Neuropathy who has these central scotomas. So look at the far periphery, these colors are all intact. The patient has normal peripheral vision, but the central vision is reduced. On the right eye, there's a large scotoma. Those hashed marked circles are where the patient can't see. But before I mention that, these are the physiologic blind spots. These are the optic nerve heads where everybody has those. And here's the central scotoma in the right eye. And in the left eye, a secocentral scotoma, which is a scotoma between center and the optic nerve. So these are classic visual field changes that we see in optic nerve disease like ethambutol. So in India, the incidence of tuberculosis is about 316 per 100,000 population. And with a population of almost 4 billion, that's over 4 million cases of tuberculosis. And interestingly, I do see patients with ethambutol optic neuropathy, but not because of tuberculosis. In the US, it's typically used for more commonly other conditions. I have 2 for Mycobacterium avium complex, for example, but the risk of vision loss is, of course, the same. Another important thing about India is that they recently revised their national TB control program to allow for actually more aggressive treatment, longer duration of ethambutol use. So they've gone from 2 months to 6 months, and increased dosing, so thrice weekly to daily dosing. And this alarmed many of the ophthalmologists and neuro-ophthalmologists that this might result in higher numbers of ethambutol toxicity. And so the thing, the question that we were trying to ask is there a way that we can predict visual recovery? So if a patient has lost vision When we see that patient, how can we tell them, I think you're going to recover from severe to mild or moderate vision loss, as we described earlier. And so we undertook this study where we looked at visual function and visual evoked potentials. There are some limitations, but this was a retrospective observational single center study at the Aravind Eye Hospital in Coimbatore, and IRB approval was obtained from that institution. We identified 30 patients, and there's a 3:2 male to female ratio. The average duration of treatment at the time of diagnosis of their vision loss was 7 months, and the doses ranged from 15 to 25. So that's in line with what we know, and I mentioned earlier about the risk comes really high at 35, and so that's a dose that's not used. The interval from onset of vision loss to stopping ethambutol was about 4 months. And once this diagnosis was made, in this country at least, in India, ethambutol, or at least in these patients, was then replaced with levofloxacin. And so this is probably the most interesting finding that we made in this study, was that patients who were on treatment longer actually presented with slightly better vision. So 20/50 for those who are on treatment longer, versus about 115 for patients who were on treatment for less duration of time. But importantly, the average vision at follow-up in both cases improved significantly. Here we're at the 20/30 level, which is about mild vision loss. And here the patient went from severe to moderate vision loss. So they gained that's about 3 lines of vision is what we would call that. So interestingly, the patients who were treated longer presented with better vision. But importantly, both groups of patients, all patients, had visual recovery simply by stopping the ethambutol. Here we're looking at how long it took to stop the medication and what that did for vision. And I think this is what we would expect. Patients who took from the onset of noticing vision loss to stopping the medicine, those patients that took longer than 4 weeks presented with worse vision. Here, this is severe vision loss, 21/20. But patients who stopped earlier than 4 weeks, so less than 4 weeks to noticing vision loss to starting the drug, presented with better vision, 20/60. So the longer they're on it, of course, the worse their vision is going to be. But again, in both cases, there was visual improvement in both by about 3 lines. So again, it's important to stop this medication as quickly as we can, but chances are these patients, simply by stopping the medication, are going to have visual improvement. The final part that we looked at was looking at using visual evoked potentials as a marker. And on the left, I've put for you some information about what a normal visual evoked potential might be. So an amplitude is typically greater than 5 microvolts, and that's the strength of the signal. So how strong is the signal traveling along the optic nerve into the brain? And the latency is how quickly does it travel into the brain? And the latency is typically around 100. So interestingly, the amplitudes were reduced in both groups, but the latencies were normal in both groups. So this shows that there is some damage to the nerve that is reducing the strength of the signal that's being transmitted into the brain, but the speed at which it goes, at least in our study, was not affected. But we did not find any significant difference between any of these groups in terms of the amplitude. It's just across the board, the amplitude is reduced. So sure, you could use VEP to help diagnose optic nerve dysfunction, but we couldn't find a way to use this to identify which patients might be more likely to regain more vision. So what about some other tools to try to help us? OCT is optical coherence tomography, which is a machine that uses light waves to measure the thickness of the retinal layers. And this, we thought, might be a way to predict visual recovery, because if you can measure the structure of the optic nerve, maybe that can translate to function. But the reality is there's several studies that have showed reduced retinal nerve fiber layer in these types of patients. Other studies have failed to show any changes while on ethambutol. And ultimately, there's really no established guideline, which is unfortunate because I love to use OCT. And so do my colleagues in India. This is pretty easy to get. And this is what an OCT printout looks like. And here, this is a normal appearing optic nerve. Everything is in green. That dark black line is in the green zone, showing that this is a normal thickness. And if I zoom into that, here you can see the thickness of the retinal nerve fiber layer in every section around the optic nerve. And then the central number is the average. And we expect an average retinal nerve fiber layer to be around 100 microns. And that's what we see in both of these, both the left and the right eye. Here's an example of a patient with a cellular meningioma who has caused optic nerve atrophy. And here, of course, look at the how much of this nerve is in red or yellow, suggesting borderline or significant thinning. And also the overall thickness is significantly down from that 100, which I mentioned is normal. Here we're down in the 60s and even in the 50s. So there's been significant thinning. So this is what we might expect to see in a patient who has ethambutol optic neuropathy. But let's go back to this patient that I showed earlier. This is actually one of my patients with ethambutol optic neuropathy, and the thinning is really not there. So interestingly, that raises this question: do these patients even get any atrophy? What is happening here? Is there perhaps some transient or subtle optic neuropathy? The bottom line is we really don't have a good answer for this. And I think some important studies that are underway and that I've been speaking with my colleagues about is how can we do pre and post ethambutol OCTs to try to measure these changes more objectively in the future. Another test is called multifocal ERG, which is an electroretinogram looking at electrical waves just in the retina, because there's some thought that ethambutol can cause retinal toxicity. Multifocal ERG can provide early and reliable detection of other retinopathies, for example, from other toxicities like chloroquine and hydroxychloroquine. Those are other classic drugs that can cause retinal disease. But there have been a couple of studies that have shown multifocal ERG changes without any visual symptoms, suggesting that it can maybe identify subclinical disease. The problem is that the changes that we see on multifocal ERG are non-specific and can't really guide us or direct us specifically to ethambutol as a particular cause. Unfortunately, we don't have a treatment for this condition. The good news, of course, is that when this is identified early, that primary prevention and cessation of the drug is the mainstay of treatment. And as I've shown you in a number of the data, as well as some of the other studies that have been done, we do know that spontaneous recovery of vision can be expected for many of these patients. We talked earlier about the role of ethambutol in chelating certain elements like zinc and copper. And so this has been an area of interest to supplement, of course, these for patients who are taking these medications, to supplement them while they're on ethambutol, but also to supplement them after the withdrawal of ethambutol in a patient who may have had optic neuropathy. These are not well studied, but there are some studies in this realm that are ongoing. So some conclusions from the study. Vision screening, of course, is essential in the first few months of ethambutol treatment, because we know that if we identify this earlier, we can probably help these patients not lose as much vision and recover more vision. It's important to stop ethambutol immediately if toxic neuropathy is suspected. And most patients will have some degree of visual recovery. From our study, at least, the best predictors of visual recovery were the duration of treatment. So we know that the patients who were on treatment a little bit longer paradoxically did better. And one of the reasons that we suspected for that is there some protective element in these patients who were able to stay on the medication longer and lose just a little bit of vision, versus the patients who lost vision earlier don't have this protective element and therefore were, developed worse vision faster. And then, of course, the speed to cessation. The faster those patients come off of drug, the more likely they are to recover more vision. And finally, at least in our study, these ancillary tests with the visual evoked potentials, at least, while it was able to indicate optic nerve dysfunction, they were not able to help us predict which patients might recover more vision versus not, whereas the duration of treatment and the speed of cessation were. And in some ways, that's kind of helpful, right? Especially in a low or middle income country like India, where cost is a factor. Patients have to bear the burden of paying for these tests themselves. If we don't have to rely on expensive testing and instead can rely on history and duration of treatment, that's better for helping us to identify patients who are at risk and helping identify which patients can recover more vision. The last thing I want to talk about is this consensus statement, which was published in the Indian Journal of Ophthalmology a little less than a year ago. This was put out by a number of prominent physicians in India. Some of them, neuro-ophthalmologist Rohit Saxena is a prominent neuro-ophthalmologist in India, as well as some of these are also pulmonary doctors that manage patients with tuberculosis and prescribe the ethambutol that we as neuro-ophthalmologists are so worried about. And I wanted to review some of this consensus statement that was put out for the Indian population. Because I think this drives home how important it is to manage these and how they go about doing it. And importantly, I mentioned screening is important, and it's a simple way to do this is to simply ask patients to screen and monitor the vision at home. And there's a number of simple tools we can give patients, like a near card, which is a card you can just print off the internet, hand them this piece of paper, tell them to hold it at 10 to 12 inches, and they read the chart every day to be sure that they can read all the way down to the 20/20 line. Another way they can check their visual field is with an Amsler grid, which is just a grid with small squares in it, and that they focus on with one eye, then the other eye, and then make sure they can see the whole grid. And if they don't, they can circle areas where they can't. And so screening patients at home is the best way to do this because it's essentially free. They can do it every single day and therefore identify really, really early if there are any changes in their vision. Patients with risk factors, however, probably should go to an ophthalmologist for a baseline exam. So we went over some of what those risk factors are. So it's age, blood pressure, drinking, smoking history, those things. If you identify that in the history, those patients probably should be seen by an ophthalmologist to manage and monitor those visual parameters. For some of these patients, routine ophthalmological exams may not be necessary. If you don't have the risk factors, routine checks can actually be done by any physician. It's very easy to teach how to have a Snellen chart on the wall and have the patient read the chart. So they're doing it at home and they can come do it when they come for their routine follow-up appointments while they're on ethambutol. That we're also reducing the burden of care on the patient that they don't have to go to another appointment. Ancillary testing, when vision loss is identified, can be useful to help confirm ocular toxicity. We talked about how visual evoked potentials can be used to identify optic nerve dysfunction. We talked about optical coherence tomography, which still may be controversial in how we use it, as well as multifocal ERG. So there are these tools that we talked about that can be used to help confirm the presence of damage, although some of these, and probably all of these, are not going to be specific at telling you that ethambutol was the cause. And actually, before I get to that one, I think that's also one of the limitations of this condition, where I think any patient on ethambutol with any change in vision, we're going to have a big desire to try to blame the ethambutol as the cause. But of course, there are many other causes of vision loss. And with so many people on ethambutol, it's important to try to really identify. And that's why it's so important, if that happens, that they see an ophthalmologist, that we rule out other things like cataract or a retinal vein occlusion, or giant cell arteritis, or non-arteritic anterior ischemic optic neuropathy, right? These other things that can cause vision loss that are not ethambutol, so that we're not stopping medications that are important for these patients unnecessarily. Finally, the treatment recommended by this group is, of course, the soft ethambutol, and a sort of a mild to moderate recommendation for the use of multivitamins, including B12, copper, and zinc. Again, the studies are a little bit out on that one, although I think in India, many of my colleagues actually do give multivitamins to these types of patients. Finally, it's important to report toxicity, and in India, there's a pharmacovigilance program where these can be reported. And the reason that this is so important is that this is the place where these types of data can be collected centrally and then disseminated at a national level for policymaking and other large decision-making that can affect the population as a whole. So thank you. And I hope that with my presentation that you've been able to see how well a country like India has been able to address vision loss and vision screening, how they've addressed it with large policy making, how they've addressed issues such as ethambutol toxicity, and how they are really doing a great job, and why so many other countries around the world send their trainees to India to learn and try to follow and copy some of the great ideas that they have come up with. Thank you for joining us today, and I open this up to any questions you might have about what I've talked about today. I'd also be happy to talk to you about our fellowship programs and other aspects of global eye care that we deal with. Thank you.
Thank you, Dr. MacIntosh. I have a hand raised already. Sam, one of our GMed students. I'm going to unmute you.
Hi, Sam.
Hi, Dr. MacIntosh. Thank you so much for that presentation. I had a question about your study. So you mentioned doing the visual evoked potentials before the improvement, but I noticed there was a point where you said that you didn't get to do it for after vision improvement. If you had been able to, despite, I guess, the results not being so robust in prediction, but what would you have expected to see if you had done the visual evoked potential after vision improvement?
Sam, thank you. That's such a great question. The first thing that I want to say is, this was a retrospective study, and so there was not any funding for it for the patients that were in it. So we were basically following the standard of care that my colleague uses, and her standard of care is she does the VEP once, right? Patients have to pay for that. And so it was just not feasible, unfortunately, for us to get those after. I completely agree, because I've spoken with her about what if we did a study where we then repeated the VEP after. And Sam, I do wonder if we would see improvement in that amplitude. At the time that we do the VEP, there is some dysfunction to the nerve, and clearly there's some improvement to that. That's why these patients are regaining and recovering some vision. And if I had to guess, I would say that I think these patients are probably regaining some vision, and therefore the VEP should improve. That's a good question, but we probably need funding to study that so that patients don't have to pay out of pocket for a second test.
Okay, anybody else? I don't see any hand raised. You can also put your question in the chat.
I apologize. I should have put my email address on there, but I'm also, you can find me in the UIC directory, and I'd be happy to answer any questions if you have them after the fact by email.
Sam, do you have another question?
Yeah, sorry. I was really curious about the Aura Lab that you mentioned. So I was curious if this was like a unique organization that I guess was like very new in terms of India, or is this something that you know of that has similar entities either like in the US or I guess globally throughout the world?
So this is an entity that is specific to Aravind. It's a standalone entity, but it is developed by the Aravind Eye Hospital. I don't know that there's an entity like that in the United States, but certainly there's other countries that are thinking about building this. I don't have that data immediately in front of me, but the Aura Lab is one of probably the most prominent example of an institution building a lab and manufacturing capabilities to make the things that they need to deliver affordable care.
Thank you, Sam. We have another GMed student with a question. Shivani, I'm going to unmute you.
Hi, Shivani.
Hi, Dr. MacIntosh. Thanks so much for your talk. I was just wondering, is there any research, or have you done any research with like assessing the incidence of optic neuropathy and ethambutol use in children? And would you expect the management of that to be any different?
So I personally have not researched that, and I also personally have not managed a child with ethambutol. All of my patients have been adults. But the recommendations, I didn't put that in that consensus statement. That was one of them. I didn't mention that one because I didn't really talk about kids, but it's the same thing. We have to stop the medication. So the management is very similar in kids.
Okay, thank you.
Mm-hmm.
Damiano has a question for you, Dr. Rondelli.
Hi, thank you for your talk. I was interested in hearing about the model you showed with the India, where wealthy patients are treated the same as the poor people. Some pay and some other are supported by the institution, I believe. Based on my experience in India in a different setting, I was wondering if besides the free of care service they may receive, is there any study, long-term study on outcome and not only the cost of the procedure, but also the infrastructure, the hospital staying, or the ability to follow up after the procedure with the physicians? Is there any quality measurements of the two settings? Experience?
Thank you for your question. And absolutely, those data exist. I don't have that. That wasn't the focus of my talk here. I don't have that immediately to present. One thing I would like to say about it is I wouldn't say that it's the same necessarily care that the free hospital gets as the patients who have insurance. My understanding is that they really focus on the basic levels of eye care. So for example, in ophthalmology, we have premium lenses. So for patients who are getting cataract surgery, you could pay extra for a multifocal lens that allows you to read near and far and not need reading glasses. So that's an example that multifocal lens would not be available in the free clinic. Those patients would get a standard lens and then would then get fitted with reading glasses for the reading component. So in some ways, the care that they get is not always the same. The basic levels of care will be met, but some of these premium things are not going to be available in the free clinic. And yes, they have looked at the outcomes and that they are as good or better than, and not just within the hospital from the free to the paying side, but also comparing to other institutions in other countries. One example that I like to talk about is cataract surgery, and the infection outcomes in cataract surgery are as good or better as they are here in the US. So they have many ways of looking at their outcomes. That would be a great talk for us to have maybe next time. Thank you.
Okay, any other questions from anybody? Okay, well, thank you, Dr. MacIntosh.
Thank you.
For everyone else, this will be available on our YouTube channel in a couple days. And please email me with any questions. And everyone have a wonderful afternoon.
Great. Thanks, everyone. Bye-bye.
Thank you.